Warm greetings to all. I am Dr. Suchitra, Professor of Biochemistry from Sri Venkateswara Institute of Medical Sciences, Tirupati. I am here with you today to talk about the topic Atherogenic Indices as surrogate biomarkers of subclinical atherosclerosis and cardiovascular risk. I would like to introduce the topic beginning with atherosclerosis, which begins early in life. It is a chronic inflammatory state associated with cardiovascular risk. In 64% of asymptomatic people between 40 to 54 years, presence of subclinical atherosclerosis was observed in one or more vessels such as the carotid, aorta, femoral and coronary arteries. Diagnosing atherosclerosis is mostly an incidental finding of a cardiovascular event with probable fatal outcomes. Hence, detecting subclinical atherosclerosis is more important, and presence of diabetes increases the risk of cardiovascular mortality by about 70%. With this introduction, the background of this study was regarding atherogenic indices, because it was found that even with LDL cholesterols within normal limits, an increase in small dense LDL levels have been reported, which is associated with subclinical atherosclerosis and coronary artery disease. And how to detect subclinical atherosclerosis? For this purpose, various imaging techniques which include vascular echography, assessment of coronary calcium score, carotid intima media thickness, which are found to detect the presence of subclinical atherosclerosis, are available. Coming to the pathogenesis of atherosclerosis, atherosclerosis is initiated with endothelial damage. With endothelial damage, the adhesion molecules recruit monocytes into the subendothelium, and along with this, LDL cholesterol particles enter into the subendothelium, and the monocytes transform into macrophages, and the LDL particles which enter into subendothelial layer get oxidized because of inflammation which is because of the cytokines released from these monocytes and macrophages, which include interleukins, which cause oxidation of LDL to produce oxidized LDL. This oxidized LDL is more prone for oxidative damage, and this is taken up by macrophages, which becomes the foam cell. This foam cell accumulates more of LDL particles and increases in size in the subendothelial layer and pushes into the lumen of the blood vessel, causing the narrowing of the lumen. And also, the smooth muscle cells will migrate from this media into the intima, that is into the subendothelial layer, and they also contribute to inflammatory reactions. So these inflammatory changes causes oxidative stress, and the oxidative stress further causes oxidation of LDL, and LDL is taken up by the macrophages, contributing foam cell propagation. When this foam cell increases in size, it becomes unstable plaque which ruptures, leading to the complications of atherosclerosis and the progression of atherosclerosis. Then coming to the lipids, the role in this atherosclerosis, we have seen LDL getting oxidized and contributing to the plaque formation. But we have HDL, which has got an atheroprotective role because it stimulates macrophage cholesterol efflux, and it is anti-apoptic. It decreases the expression of adhesion molecules, therefore it's anti-inflammatory. It decreases the LDL oxidation, and it saves the endothelium from damage. So it is of beneficial molecule. Now coming to how do we address the subclinical atherosclerosis, is prevention at the level of subclinical atherosclerosis generation, that is primary level. And this is called as primary prevention. So with primary prevention you take this, there are a lot of risk factors and which have to be addressed, and this is called as primordial prevention, that is the behavior, the environment and genes control this, which we can control to an extent in the environment. So when you see subclinical atherosclerosis, you can see the progression of subclinical atherosclerosis to an atherosclerotic cardiovascular disease. So if you address this atherosclerotic cardiovascular disease, it is called as secondary prevention. But if you address the subclinical atherosclerosis, it is called as primary prevention. And we are focusing on this primary prevention to prevent the cardiovascular event from happening. So how do we address this? We have a lot of imaging techniques, as I told you, like coronary calcium score, ultrasound plaque imaging, and we have biomarkers, and we have genetic markers. So these are the ones which are coming into the arena for diagnosing subclinical atherosclerosis much earlier before the cardiovascular event occurs. Now coming to the atherogenic indices and cardiovascular disease. A strong correlation was reported between the lipid ratio, that is total cholesterol by high density lipoprotein, atherogenic coefficient and atherogenic index with the carotid intima media thickness values in prediabetes. So they found that lipid ratios and atherogenic indices are reported to predict the risk of occurrence of coronary artery disease in subjects with hypertension or diabetes, even in the absence of a markedly deranged lipid profile. So this is why we are focusing on atherogenic indices, because dyslipidemia may or may not be evident, and so in that situation we can use the atherogenic indices to assess the CVD risk. In this scenario, lipid ratios have been found to contribute significantly to the assessment of coronary artery disease risk. Therefore, the need of a surrogate biomarker arises. So, for a biomarker to be considered as a surrogate biomarker, the following criteria need to be fulfilled: the ease of measurement, the association of the marker, which is going to be considered a surrogate biomarker, with the clinical endpoint, and the ability of the surrogate biomarker to be able to produce an estimation of the risk, and the utility of the marker related to the disease progression. So with this aim in mind, we went ahead to do the study on association of atherogenic indices with carotid intima media thickness in type 2 diabetes subjects who are having subclinical atherosclerosis, based on the CIMT measurement by carotid Doppler ultrasonography. We got group 1 subjects who are 60 in number, who are healthy controls, who had CIMT less than 0.57 millimeters, which is taken as the cutoff value for detecting subclinical atherosclerosis by CIMT. Group 2 were the study subjects who were 60 in number, who were type 2 diabetes with carotid intima media thickness more than or equal to 0.57 millimeters, indicative of subclinical atherosclerosis. We went to calculate lipid parameters such as VLDL, calculated as triglyceride by 5, LDL, calculated as total cholesterol minus VLDL plus HDL, and non-HDL cholesterol, which is coming under the ATP3/4 guidelines as one of the indices for detecting CVD risk, which is got by subtracting total cholesterol from HDL cholesterol. Lipid ratios and atherogenic index, which is calculated as atherogenic index, which is a logarithm of the triglycerides divided by HDL. Castelli's risk index, which is CRA1, which is calculated as total cholesterol by HDL. Castelli's risk index 2, calculated as LDL by HDL. Atherogenic coefficient, calculated as total cholesterol minus HDL divided by HDL. So these lipids ratios were calculated from the estimated lipids of lipid profile. So when we saw the results, you can see in table 1 the anthropometric indices and lipids among the study subjects. We saw waist circumference, hip circumference, triglycerides, VLDL and HDL were found to be elevated in the diabetic groups compared to the controls. You can see the waist circumference is 81 in controls and 87, and hip circumference 92 in controls and 96, which is significant. Triglycerides 101 in controls and 165 in diabetes with subclinical atherosclerosis. VLDL also is 33, that is elevated. HDL is also decreased, which is 52 in the controls and 40 in type 2 diabetes. A significant decrease in HDL was observed. Coming to the atherogenic indices, which was calculated in these subjects, we found that atherogenic index was significantly higher in the diabetes compared to the controls, as found by 0.30 in controls, 0.58 in type 2 diabetes, and CRI1, which is 3.4 in controls, which is 4.22 in diabetes, and CRI2, which is 1.99 in controls, was found to be 2.37 in type 2 diabetes, which was not significant. Atherogenic coefficient, which was 2.41 in controls and 3.29 in diabetes, is significantly elevated. So these changes in atherogenic index, CRI1 and atherogenic coefficient were found in the diabetes patients with subclinical atherosclerosis compared to the controls. Coming to the correlation of CIMT, now these atherogenic indices are elevated in type 2 diabetes patients with subclinical atherosclerosis. And how are they correlating with the carotid intermediate thickness, which is a measure of the subclinical atherosclerosis? So we found that the table 3 shows the correlation of this carotid intermediate thickness with the anthropometric indices and atherogenic index. So we found that you can see the carotid intermediate thickness has a correlation with waist circumference, hip circumference, BMI, with triglycerides, with VLDL, and negative correlation with HDL, and a positive correlation atherogenic index, and CRI1 and atherogenic coefficient. So CIMT has got a correlation with all the anthropometric indices and atherogenic indices. Coming to table 4. Now we have found that the atherogenic indices have a relationship with the carotid intima thickness. Now we wanted to see which of these atherogenic indices has a predictive value of detecting subclinical atherosclerosis by receiver operating characteristics curve used to assess the diagnostic utility of the atherogenic indices in subclinical atherosclerosis. As we can see in table 4, atherogenic index and CRI1 and atherogenic coefficient have good area under the curve, which has got a good sensitivity and specificity, especially for atherogenic index with significant p-values. So they have a good diagnostic ability for detecting subclinical atherosclerosis in type 2 diabetes subjects. Coming to the discussion, relationship of lipids and atherogenic index. We found in this study significant changes were observed in subclinical atherosclerosis compared to controls, where among the anthropometric indices, waist circumference, S circumference, hip circumference were significantly higher. Among lipids, VLDL and triglycerides were significantly higher, and HDL was significantly lower. We do not find any changes in the cholesterol and LDL levels. Among the atherogenic indices, atherogenic index, atherogenic coefficient, and CRI1 were significantly higher, and HDL was found to be negatively correlated with all the lipid ratios and atherogenic index, indicating that lower HDL levels are a risk and are associated with the increased in the atherogenic indices, which indicate the atherogenic potential. And CRI1 and atherogenic coefficient were found to have significant negative association with each other. And coming to the lipids in the study, subclinical atherosclerosis has been reported with LDL cholesterol as low as 70 milligrams per dl, with the prevalence increasing with higher LDL levels. And triglycerides more than 150 milligrams per dl are reported to be associated with the risk of subclinical atherosclerosis. And CRI1, also known as cardiac risk ratio, has been particularly reported to be associated with carotid intermediate thickness, and hence indicates the vulnerability to coronary plaques formation. Atherogenic coefficient is a measure of cholesterol in the LDL, VLDL, intermediate density lipoprotein fractions with respect to HDL, and it's reflective of the atherogenic potential of the lipoproteins. So that is the importance of the atherogenic indices. Coming to the relationship with the CIMT, the increase in CIMT is reported to be due to increased expression of addition molecules promoted by high triglycerides, LDL and lowered HDL levels. CIMT was found to be significantly associated with elevated triglycerides, VLDL and atherogenic index, CRA1, atherogenic coefficient and with lowered HDL levels. So relationship of this CIMT, which is established indicator of subclinical atherosclerosis, is being found with the lipids as well as atherogenic indices. Now, why should we consider atherogenic index as a surrogate biomarker of CIMT? Because there is a variable degree of chronic inflammation can cause fluctuations in the individual lipid concentrations, making them less reliable in some situations and therefore not making them give the CVD risk less clear, while atherogenic index is less susceptible to these fluctuations. So lipids are fluctuating because of inflammation and they cannot assess the impact of changes of these fluctuations on CVD risk is less clear. Atherogenic index reflects the balance between the protective and atherogenic lipoproteins and is altered by increased triglycerides or reduced HDL levels and correlates with small dense LDL. So atherogenic index can give an assessment of small dense LDL levels without measuring the small dense LDL levels by using this ratio. And it is found that atherogenic index values have been classified as 0.3 to 1 for low risk, 0.1 to 0.24 for medium risk, and more than 0.24 for high risk for coronary vascular disease. And it was found that atherogenic index at a cutoff value of 0.38 in our study had greater sensitivity and specificity, indicating its diagnostic utility in predicting the presence of subclinical atherosclerosis. To conclude, it has been proposed that conventional lipid parameters using either LDL or HDL alone is inadequate for prediction of cardiovascular risk, especially in individuals with intermediate risk. Hence, calculated indices have gained importance as supplementary tools in CVD risk assessment. Atherogenic indices, which were higher in subclinical atherosclerosis, were found to correlate with carotid intima media thickness, indicating that these indices perform on par with CIMT. And also, these atherogenic indices, CRI1 and atherogenic coefficient, were found to have good diagnostic potential for detecting subclinical atherosclerosis in type 2 diabetes, with AI having greater sensitivity and specificity. So this study, the take-home message from this study is that even in the presence of normal cholesterol and LDL levels, atherogenic index was comparable to CIMT in detecting the presence of subclinical atherosclerosis. Hence, atherogenic index can be considered as a simple and cost-effective surrogate biomarker of subclinical atherosclerosis, as it has found to have higher sensitivity and specificity compared to the other two indices. So with this, I conclude saying that atherogenic indices are going to be potential supplementary tools for detecting the CVD risk in the case of unreliable lipid profile which appears to be normal, but the underlying changes can be identified and detected by these atherogenic indices, which does not cost much, because with the existing lipids it can be calculated, and though individual lipids do not give the presence of risk, the calculated ratios do indicate the minor changes and which can be indicative of CVD risk in patients. Therefore, it can prevent the onset of this CVD events by detecting earlier at the level of primary prevention, at the level of subclinical atherosclerosis before the evident disease and severity outcomes appear. So thank you for giving me this opportunity. Have a good day.